For a couple of minutes, I'm going to provide a little bit of background, and then we're going to cross to Professor Thomas Zeller in Bad Krozingen for a live case. We'll do that very shortly. We're then going to hear from Marianne Brodmann from Graz in Austria. Many of you know Marianne on the data supporting intravascular lithotripsy. And then I'll show a pre-recorded live case that we did about a week ago at Auckland Hospital. We'll then ask Dr. Arne Schwitt from Münster in Germany to show some more real-world case experience. We'll have some discussion both at the end, but also we'll have some discussion as we go through the cases and the live cases. But we're really interested in this problem of arterial calcification. We know that this is a real problem. It compromises outcomes with angioplasty, high incidence of dissections, residual stenosis and perforations. Stents don't expand well with this kind of technology, and we have a lot of signal that in fact it interferes with drug uptake using our drug-eluting technologies. For many years we've known about the value of lithotripsy, particularly our urology colleagues have used lithotripsy to treat renal calculate, taking advantage of the technology which is hard on calcium but actually soft on soft tissues. So in fact the low morbidity of this procedure has been very important. And this intravascular lithotripsy concept is one really borrowing that concept to produce lithotripsy emitters combined with an angioplasty catheter to treat calcified arterial disease. Here's really what the Shockwave intravascular lithotripsy system looks like. So here are the lithotripsy emitters, as you can see here, integrated with an angioplasty balloon. This is then used to connect to an intravascular lithotripsy cable and via a connection system to a generator. It's very quick, simple and easy to use, and it's based on an 014 guide wire angioplasty platform. So the basic concept is to create apposition of the angioplasty balloon to the vessel wall at very low pressure to perform lithotripsy to create, as we'll see, microfragmentation of the calcium in both the medial and intimal layers, change the compliance of the artery, and then allow the balloon to dilate out to nominal diameter at low pressure and hopefully with a low incidence of residual stenosis or dissection. So this uses unfocused lithotripsy energy that is created at the multiple emitters in the system, and then this energy traverses through the fluid in the angioplasty balloon. It actually creates steam bubbles, as you can see, that expand and collapse and create sonic pressure waves. And it's these sonic pressure waves that then come into the contact with calcium and cause transient shear pressure and various shear mechanisms to microfragment the calcium. Interestingly, it appears that the calcium, although microfragmented, is very stable in terms of any risk of embolization. Our experience initially was with the embolic protection filters, and we did not yield any embolic material, so we can microfragment the calcium in the various layers without a significant embolic risk. And the proof of concept has really been shown in multiple ways, both in the coronary and peripheral arteries on high-resolution optical coherence tomography, where you can see you have very controlled dissections and microfractures of the calcium, but also changes in appearance of the calcium on both ultrasound and OCT, as I'll show you later in this session. And we can also see the same thing if we're applying this technology to a heavily calcified aortic valve. So really, the realm of possibilities are really enormous for this. Of course, we're focused in the coronary and peripheral arteries as a standalone treatment, but particularly in combination with drug-coated balloon technology, where indeed it may be that we are enhancing the effect of the drug by performing not only luminal gain, but changing the compliance of the vessel, obviously improving drug-eluting stent apposition if we need that. But as you've seen, there are also applications in terms of calcified aortic valves and TAVI, and also in heavily calcified arteries to produce arterial access. So without further ado, with that little brief introduction, I think we're going to now be able to cross live to Bad Krozingen and to Professor Zeller, to Thomas.